Thank you, everyone, for joining us today. My name is Glenn Beebe. I'm with the Intermountain Media Relations team. We'd like to thank you for joining us for our COVID community update. We are joined today by Dr. Brandon Webb. He's an infectious diseases physician with Intermountain Healthcare. We're also joined by Dr. Andrew Pavia. He is the chief of the Division of Pediatric Infectious Diseases at the University of Utah Health and director of hospital epidemiology at Intermountain Primary Children's Hospital. Gentlemen, we want to thank you both for joining us. We're joined by members of the media, and we are also joined by some viewers on Facebook. If you have any questions, please put them in the chat, and we will get around to asking them. Gentlemen, I just want to start off. The Health Department just released some new numbers. I'm going to read them off. They're released now on a weekly basis. Right now, 4,504 new cases since last Thursday. 4 new deaths reported since last Thursday, and now a total of 4,765. 118 patients currently hospitalized for COVID-19. 18 of those patients are in the ICU. We have a 15% test positivity rate and a 26.5% wastewater sites are seeing elevated or increasing across the state. Dr. Brandon Webb, let's just start with you. What does this mean? Is it something that's concerning, and what are you seeing in our hospitals? Sorry, Dr. Webb. Go ahead.
We're in a surge phase again. And what we were watching is how that's played out across the country, and especially in other areas of the world that typically precede the United States. And I'll say I'm not surprised by the report of today's numbers. I think it's a significant undercount, and you can surmise that from our high test positivity. But I think that the way this particular surge is behaving elsewhere, we should expect to continue to rise for at least another 4 weeks or so, would be my guess.
And what does it look like as far as hospitalizations? Are we seeing very full hospitalizations? You heard the number 118. That doesn't seem like our height, but considering everything else that's going on in medicine, what is that looking like?
So we're seeing similar to what we've seen throughout the Omicron surges. We're seeing fewer hospitalizations with respect to the total overall cases. But as the case counts go up, and especially given that we can't measure the accurate number of cases and transmission in the community, we do expect to see our hospitalization rate continue to go up. We're seeing that on the East Coast. We're seeing that in Utah.
And Dr. Pavia, just from the pediatric side, we know that throughout the entire COVID pandemic that it's always hit pediatrics a little bit different, even with the different variants. What are you seeing at primaries, and how is that? What are you seeing as far as case rates and hospitalizations?
As Dr. Webb just mentioned, it's actually kind of hard to track case rates because most parents are testing their children with home tests. And so they're not showing up in the numbers. But the test positivity for children has also increased probably 5-fold over where it was at its lowest in early April. We're getting more and more calls about sick children. Luckily, we haven't seen hospitalizations increase dramatically yet. And we hope that because of a reasonable amount of vaccination and herd and immunity in the population, we're not going to have the same kind of impact on hospitalizations that we saw in December and January. I don't think people really appreciate how hard the fall wave of Delta and the winter wave hit children. I mean, the number of kids who were hospitalized in Utah was really unprecedented. We do have an impact that we haven't really talked about, and that is our hospitals are pretty full with run-of-the-mill patients that, and there's very few beds, but we have a major staff shortage in all of our hospitals. And right now, we're experiencing a lot of staff absenteeism due to people calling in with COVID. And that is really putting pressure on our ability to deliver care. And that's what I really worry about for the next 2 or 3 weeks, rather than seeing a huge amount of severe illness in children.
And tell me a little bit, because recently, there was approval, or at least draft approval for a booster for 5 to 11-year-olds. Tell us a little bit about that and what role that will play in hopefully keeping the virus at bay in the younger population.
Well, it's become very clear that as the virus has changed over time, and as immunity has waned both from your first infection and from your first 2 doses of vaccine, that really effective vaccination for all age groups requires 3 doses. And it's really a major step forward that we now can offer a 3-dose schedule to children 5 to 11, the same way we do for older adolescents and adults. And the 3rd dose is usually even safer than the original doses. Side effects are similar or slightly less. So it's really necessary for kids 5 to 11 to complete their immunity. And there's really not much downside besides talking your child into the fact they need another shot.
And Dr. Webb, this one's for you. Just tell me a little bit, what steps should people be taking? Is this something we should be concerned about? As you know, masking requirements on planes and in other places have been lifted. When you go out in public, you don't see a lot of mask wearing again. Should we be taking those steps again, or are we at that point yet?
Yeah, I think we need to look at this a little differently than we have been over the course of the pandemic. COVID is here to stay, and we need to learn how to navigate this new environment where COVID ebbs and flows at different times with different variants. We have the tools that we need to be successful. And those tools include strategies that were not appropriate early on in the pandemic, when the overall immunity in the population was nil or very low. Now we have a significant amount of immunity in the population. It's partial immunity, but it's very important. And the most important benefit of that societal immunity is that it tends to reduce the severity of disease for individuals who have sufficient immunity. And what that means is that we're seeing more cases that are mild in individuals who have immunity, even if it's partial. We're still seeing severe disease, and severe disease results in hospitalization, ICU admissions, and death. That is a big focus, and the patient populations that are still experiencing severe disease are predictable. And at this point, one of the most important parts of our strategy to live with COVID as it ebbs and flows is one of personalized or individualized risk reduction. People need to understand their risk. They need to understand the risk of those around them. And then they need to make both preparation and prevention part of their COVID package, if you will. What I mean by that is risk is fairly predictable. Risk really has to do with 5 things. It has to do with your immunity overall. And vaccination, like Dr. Pavia said, remains a critical part of achieving immunity, both on the individual level and at the population level, in a safe way. We also know that if you've had COVID, that also plays into your overall immunity, and that cross-trains the immune system in a very important way. Age plays a big part of risk, as does health. People's overall health and number of medical conditions plays a big role in how likely it is that they get severe COVID. The activities and other behaviors that people choose to engage in plays a big role. And then how prevalent is COVID at any given time. Those 5 things can be used to identify an individual's risk. And once you know your risk, if you're high risk, there are important things that you should do to both prepare for a time when you may get COVID and to prevent getting COVID.
Thank you. Dr. Pavia, just any thoughts on top of that? Anything different you would say for the younger population when it comes to what steps they should take?
I think one of the important things everyone has to think about is their individual risk, as Dr. Webb was just explaining, but also the risk of their community. So you might be a 25-year-old who's had 3 doses of vaccine and has recovered from infection. You're pretty well protected. But let's say you work in a nursing home, or you have a child at home who has cancer, or you're around neonates. Then you need to think about what's the risk of your passing it on to other people who will get much sicker. If that same 25-year-old only hangs around with other fully vaccinated 25-year-olds, that's a very different profile than somebody who works with the elderly, works with the very young. And I think we haven't emphasized that enough. We too often focus on our own risk rather than the risk of our broader community.
Thank you. And let me now go to some of the questions. Chris Reed with the St. George News. And this one will be for Dr. Webb. We're hearing about the virus spreading right now, even more, yet hospitalizations are staying down and deaths are in the low single digits. Some skeptics may say, is it worth worrying about this right now? How would you respond to that?
Well, I think that what we need to do is look at it in terms of strategy. Do we need to shut down like we did in March of 2020? No, absolutely not. Do we need to have a plan? Do we need to have a strategy? Absolutely. Because although hospitalizations and deaths have been decoupled to some degree from the overall case transmission, they still impact lives and livelihoods. They still impact our circle of friends and family, like Dr. Pavia was mentioning. And so that gets back to this concept of COVID strategy is no longer one size fits all. And right now in most of the country, we're in a medium risk environment. And in a medium risk environment, individual risk reduction is key. And I want to just second what Dr. Pavia said, because individualized risk or personalizing your risk reduction means doing things to prevent getting COVID, to prevent getting severe COVID, and making changes if necessary in your behaviors to prevent passing it on to those with whom you associate who might be vulnerable.
And just one follow-up from Chris Reed. Is there any worry about them when we start urging other precautions for the population that there might be a cry wolf syndrome, that people might start ignoring it?
I think there certainly is COVID fatigue already. What we're looking at are metrics that are key downstream metrics like hospitalization, ICU admission, and death. But we're also looking at long COVID, which is under recognized and makes a significant impact as well. There's absolutely still a rationale for preventing COVID-19 in our community, even when hospitalizations and death are lower by proportion than they have been in other surges.
And Dr. Pavia, let me ask you, because one of the things that's been unique about COVID is that each time around, sometimes we start to see different symptoms, or things tend to be more prevalent with one variant or the other. One of the Facebook questions we have is, are the symptoms different this time around? And I'm also wondering if you can maybe elaborate if kids are seeing different symptoms than adults.
So this surge is being caused by subvariants of the original Omicron that we saw starting in December and January. And there was a little bit of a change in symptoms as we moved from the older strains like Alpha and Delta to Omicron. We saw more upper respiratory symptoms, more sore throat. In children, we saw more croup and bronchiolitis and a little bit less pneumonia. We don't really have enough experience yet with these subvariants, the BA.2, BA.2.12.1. I know this is a mouthful, but we don't have enough experience yet to say how different are they clinically than the original Omicron in terms of symptoms. What we can say is that unfortunately, these new variants are able to infect people with partial immunity. So if you've just had Omicron, just had 2 doses of vaccine, you're quite susceptible again. If you have higher levels of immunity because you've had 3 doses of vaccine, or 2 doses of vaccine and an infection, or best yet, 3 doses of vaccine and an infection, you're pretty well protected, but others not so much.
And let me go off of that a little bit, since you mentioned that. We have a question from Lisa Riley Roche with the Deseret News. What would you say to people who think they no longer need to worry about getting COVID-19 because they had the virus during the Omicron surge? Are there new different subvariants infecting everyone, even though they've had Omicron?
Yes. So these are subvariants of the original Omicron that are descended from it, but they differ in some important ways. And the most important way is that they are not neutralized. That is, they're not prevented very well by antibodies to the original Omicron. So we know immunity fades with time, and these viruses are more resistant. So if you were infected in December, that's 6 months ago. So with a different virus and 6 months having passed, your protection was pretty good in March, but it's not so good anymore.
Glenn, maybe we could talk for just a minute about what that means with respect to choosing when to be boosted.
Yes.
Because
yeah,
I think
go ahead.
What Dr. Pavia just said matters a great deal in terms of knowing one's risk. So what you heard Dr. Pavia describing was this concept of immune cross-training, if you will. And the more touches with the virus you've had, and especially the more safe touches through vaccination you've had, the more robust the immunity is against these new variants that continue to emerge. So someone who's had several doses of the vaccine, or ideally 3 doses, and then has a breakthrough infection, tends to have more mild disease. That's absolutely true. Severity is significantly reduced as the number of vaccination doses increase prior to getting COVID. So vaccination is a really important protection against having severe COVID. But if you do get a breakthrough infection and are fully vaccinated, your symptoms tend to be more mild. They tend not to last as long. And we actually have data that suggests that you tend to have less lingering symptoms, less long COVID. Those are all really important benefits to having been vaccinated, even if you do get COVID-19. Now, there are a lot of individuals who have had 2 doses and a booster, but their booster now was in the winter. It was six months ago or so. The question has been circulating: who should get the 4th dose or second booster, if you will, and when? And I think that goes back to risk again. So if you're an individual who had 3 doses and has had COVID-19 recently, you probably don't need to get the booster immediately, but should be thinking about getting it later this summer in preparation for the fall. If you're an individual who has not yet been boosted at all, now is a very important time to get that booster, because there are variants circulating right now to which having more robust immunity would benefit significantly. So high-risk individuals, 50 or older, or immunocompromised, should think about getting boosted now. Individuals who are at more moderate risk, especially if you've had COVID recently, should think about getting boosted, but might think about later in the summer as a protection for what's coming in the fall.
And Dr. Webb, as you kind of mentioned severity of disease, that there was another question in the chat. They're wondering if you can elaborate on severe disease being predictable. Is it more likely a risk for populations or just the unvaccinated?
Well, we do know with a fair amount of certainty who gets hospitalized, who gets severe COVID-19. It tends to be individuals who are unvaccinated or undervaccinated, and individuals who are fully vaccinated or fully vaccinated and boosted, who are older and have a combination of advanced age and multiple comorbidities or chronic medical conditions, or who have a compromised immune system. Those are the 2 groups who are at high risk in particular for severe disease: individuals who have not been vaccinated or have not been fully vaccinated, and individuals who, despite that, haven't made a robust response to the vaccine and just are less healthy or older. And it's really the combination of age and medical conditions that puts one at risk.
And Dr. Webb, we have a question from Nick McGurk. who seems to be getting long COVID the most? And can you elaborate on wastewater tracking and what that's telling us?
I'll tackle the long COVID and then I'll punt to Dr. Pavia for the wastewater. You know, it's interesting. We're learning a lot about long COVID, but I think we're still very early in our understanding of long COVID. We do know that the more severe illness you get, the more likely it is that you have lingering symptoms or long COVID symptoms. So patients who are hospitalized with COVID tend to have much higher rates of long COVID. We also recognize now that long COVID tends to occur in patients who are overall less healthy to begin with. But there are things about long COVID that we don't yet understand well. There are certain symptoms that take advantage of individuals irregardless of their age or their medical health. And we still need to understand more to be able to predict who's at highest risk of getting long COVID.
Dr. Pavia, do you mind talking about just how the wastewater tracking is playing into all this?
Sure. So wastewater tracking is a new and innovative way of trying to measure virus when people aren't coming in for PCR testing. They're doing home testing or they're maybe not testing at all. It's because it's relatively new, there are a lot of challenges in terms of knowing what numbers are specific target levels that represent specific action levels. But what we can say in a general way is that when the amount of virus in the wastewater, basically that is showing up in people's excretions, is going up, that it correlates very well with the amount of disease in the community going up in the next couple of days to weeks. So it's not a perfect tool, but it's another way of measuring things when it's not easy to measure total disease burden. I did want to say something about long COVID in children, because parents are probably wondering about that. And it is definitely a problem for children. It seems that a smaller percentage of children who get infected end up with long COVID. Best numbers we have, and there's still a lot to learn, are probably 1 in 10 to 1 in 20. But it does occur sometimes in children who've had very mild or even asymptomatic infection. And it can be really life-changing and debilitating. So as we're focusing less on people ending up on ventilators and dying in large numbers, we have to really think about this big burden of children and adults who are really having their lives changed for months on end, and figure out, how to prevent it and how to treat it.
And we have another question from Chris Reed for you, Dr. Pavia. How are the current strains affecting kids?
It's difficult to get exact measurements because of the decreased testing among children. And because so many children were infected, both during the Delta wave and Omicron wave, there's partial immunity out there. I think what we're seeing, as best we can tell, is a lot of infections in children, but they are by and large not as severe. Now, I worry that protection is not going to last. As we get farther out from the original Omicron surge and from the first doses of vaccine, that protection we know will wane and disease will be more severe again. So what we see in the late summer and fall may be very different.
And can you talked about waning. Can you maybe talk a little bit, expand a little bit more on the booster? Should kids be getting it right now? Dr. Webb talked a little bit like maybe who should wait, who should get it right now. What's your advice for kids out there in that kind of 5 and above range?
Yeah, it's a great question. One that I think is probably the first thing parents think about when they saw that, or when they're going to see this evening that CDC is recommending booster for children. I think, again, you need to think about it in terms of individual risk. So if you got your first 2 doses as soon as vaccine became available, then you are getting out more than 6 months, 8 months, so your immunity is starting to fade. If you were a late adopter and got your vaccine in March, then you're probably in reasonably good shape. The other thing is to think about exposures. If you're going to spend your summers outdoors, then you probably want to maximize your protection when it's time to go back to school, when the risk of getting COVID and of missing a lot of school or bringing it home to your vulnerable family members is highest, you may want to get that booster in the fall. If, on the other hand, you're planning on a lot of travel and crowded spaces and indoor exposures, places where the family might get trapped if somebody tests positive, then you may want to make sure that everyone in the family has had 3 doses before you plan your summer travel. It's complicated having to make these individual decisions. It'd be easier to say, rush right in and do it this week. But I think that's the reality of the phase we're going into. You need to think things through in terms of how it affects you, your family, and the people around you.
And Dr. Pavia, let me ask, one of the things that we heard about early on was that they were trying to see if kids 5 and under could get the vaccine. Is there any update on kind of where the studies are on that? Or we know that there was some data that came out, but maybe it wasn't as good. Where are we at with kids under 5?
So we're going to learn a lot more on June 6th when the FDA meets, and they're going to release all of the available data they have on both Pfizer and the Moderna vaccine for children 6 months to 5 years of age. What we know right now, we know mostly from press releases, and it looks like the Moderna vaccine with 2 doses had a very good immune response. The Pfizer vaccine was given in a really tiny dose to younger children, 1/10 of what adults were getting. And 2 doses at that small dose did not work terribly well in terms of the antibody response. Pfizer's put out a new press release suggesting that that 3rd dose brought the antibody levels up a great deal. It sounds like, from what we know, that the safety profile is very, very good and the antibody responses are very good, but we're not going to see the full data until a few days before the FDA meeting. And so I'm going to kind of reserve judgment a bit, but I'm very hopeful that, you know, the real science looks as good as the press releases, which is always a risk. And if it does, then I think the long wait may be over after January 6th or thereabouts. I'm sorry, June 6th, not January 6th. People have been waiting way too long. They're going to string me up by my heels if they have to wait till January 6th.
Yeah, no, thank you. And Dr. Webb, another question we have from Lisa Riley Roche. How long can we expect this surge to last, and what are the expectations for fall?
Forecasting is always a slippery slope. The best we can do in terms of forecasting is to project based on the kinetics or the way the virus has behaved in the past in similar situations, the way it's behaving in areas that tend to be ahead of us in terms of these surges. And generally speaking, once a surge starts, as long as a second variant doesn't piggyback on the first, we generally tend to see a peak around 60 to 80 days after the surge starts. So currently, this BA2 surge started about 4 weeks ago. And we are seeing, like Dr. Pavia said, a subvariant entering the mix here with the BA2.12.1. And that may prolong the current surge. But I think right now we're expecting to continue to see cases rise through mid-June at least. And then we're really going to have to reevaluate and see what other variants are on the horizon.
And I just add, Glenn, that the more you know, the less you know in terms of predicting. This virus changes and it has defied our ability to model beyond about 4 to 6 weeks. As Dr. Webb was explaining, we can make some pretty educated guesses about the next 4 to 6 weeks. But while we can say some broad things about the fall, our crystal balls are cracked and covered in mud when it comes to projecting that far out. It is likely that when kids go back to school and people move indoors, and when another 6 months have passed since people got their vaccines and their first infections, that they'll be more susceptible and cases will rise again. But, we're just going to have to wait and see. It's not a popular answer, but that unfortunately is the best we can do scientifically.
Thank you. And Dr. Webb, and this can actually be a question for both of you. Even with this current surge, we've been at this now for more than 2 years. What do you say to people who may still be skeptical, not maybe even about the virus? This question's from Jamie, but also maybe about vaccines. What do you say to people who might still be skeptical or see that numbers aren't as high as they have been in the past and think this maybe isn't a big deal?
Well, what I would say is that a big deal is relative. You know, for somebody who is in the ICU, even if there are very few others in the ICU, it's a big deal. For somebody who gets long COVID and their life is significantly impacted, it's a big deal. But at the community level, like we talked about at the beginning, the way we navigate COVID going forward needs to be intentional. It needs to have strategy that matches an environment where we need to be able to flex and use the tools that we do have. We need to protect those who are vulnerable. We have vaccination data now that is robust, and we understand that vaccination has tremendous benefit both for individuals and for society. And we really need to just continue to move towards a model as a community where, although we're tired of COVID, we're not putting our head in the sand. We're continuing to make good choices as individuals and as a community to make sure that we protect those who are most vulnerable and we prevent COVID wherever possible.
And Dr. Pavia?
Yeah, I think I'd add to that, you know, there have been a million Americans who have died, a million Americans, more than in all of the wars that we fought put together. So we're approaching about 1,600 deaths among children. That is about 16 winters worth of influenza deaths. You know, it may not seem like a big deal if it hasn't landed on your front door, but this has been a once in a lifetime changing event. And just because you've been lucky not to be severely impacted yourself, you should really think about your neighbors, your community, the people in your congregations who've been affected, and the things you can do to help protect them.
All right, Dr. Pavia, Dr. Webb, I see no more questions. I want to thank you both for joining us today and those answers and helping keep the community informed. And thank you to all the members of the press and everyone on Facebook who also joined us. We'll also be sending out a link shortly to this entire recording so you have it. Thank you so much and have a good day.
Thank you.
Thank you.